morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today webinar is Professor Wenya Lindabai from Department of Neurosurgery, Brigham and Women's Hospital, Boston, Massachusetts, United States of America. She's also an associate fellowship director, associate program director, and co-director Scientific Advisory Committee at the BWH. She's also the core course director, Brigham and Women's Cerebrovascular and Skull-Based Annual Symposium. She's a neurosurgeon with deep interest in patients with benign and malignant brain tumors, focusing on mechanism underlying glioma invasion and tumor microenvironment. She has received several awards for her outstanding contribution to neurosurgery, especially the very recent Presidential Fellow Award of Brigham and Women's Hospital. She has mentored several residents and observers during their stay at MGH. She also has been invited to faculty who have been given several lectures in national and international conferences and symposiums. She is also an innovator who have developed a molecularly integrated grade of meningioma and intraoperative neuromonitoring mapping strategy for deep-seated tumors. We are extremely honored to have her today at our webinar, and she will be talking about multimodality surgical approach to deep-seated brain tumors. The chair for the first session of today's webinar is our honored guest from Japan, Professor Manabu Kinoshita. Professor Kinoshita is a professor and chairman of neurosurgery at Asahikawa Medical University, Hokkaido, Japan. He was the previous director of the Department of Neurosurgery, Osaka International Cancer Institute. His clinical interests are focused upon surgical neuro-oncology. His main clinical and research activity are including those performed at the Osaka University Graduate School of Medicine. He's also expert in operating malignant brain tumor surgeries, including awake surgeries for glioma. He deeply believes in non-invasive imaging techniques, which are valuable information to enhance surgical precision and also provide tailor-made treatment for glioma patients. He has been participating in MR-guided focused ultrasound surgery and demonstrated for the first time that macromolecules such as antibodies could be delivered beyond the blood-brain barrier at a site-specific fashion by MR-guided microbubbles enhanced focused ultrasound. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both speakers and chairs and our audiences to this online platform of the ACNS webinar. A warm welcome to our colleague in China. And again, we are extremely grateful to Professor Zubin for broadcasting this webinar on WeChat channel. Dr. Ben from Hong Kong is my co-host today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Manabu Kinoshita. Professor, please. Thank you.
Thank you very much for the kind invitation and introduction, Dr. Lee. So it is my great honor to have the first presentation from Dr. Wenya Linda B. It is my really great pleasure because I am one of the Brigham's alumni, and I miss a lot from what I learned at your institution. So today her talk will be about multimodal approaches for deep-seated brain tumors. And I can't wait what kind of presentation that you're going to give to us. All right. So Dr. B, go ahead with the presentation. Thank you.
Thank you for the kind introductions and a true pleasure to join all of you today. I have the pleasure of talking about a subject that is near and dear to my heart, which is applicable to a range of tumors, whether deep-seated or superficial. I have the privilege of serving a cancer institute where many patients come in for the second, third, fourth opinions and are told that their tumors are either unresectable or unsafe for extensive surgical resection. Because of that experience, I hold deeply the belief that surgery should be conferred because it may provide improvement in quality or quantity of life and not be deterred by the location of the tumor. With that, the consistency of safe outcomes, especially for aggressive tumors, becomes critical in these patients because surgery should only advance and never deter the timing of treatment that ensues thereafter. How do we do this on a consistent manner, such that there is no statistics or probability that we can offer the patient, but instead have surgery be the easiest step in their treatment pathway? And of course, anatomy is the road that we walk on in terms of the basis of our clinical decision-making, attack of surgical approach. However, that road in the individual patient, the map of that road, I would say, is imaging. Specifically, I would like to highlight the role of structural imaging sequences that can be easily accessible worldwide without the use of additional applications, software, or even processing. I'll highlight the impact of T2 sequences. As you can see in the middle of these pictures, in this 3D T2 space compared to a 2D standard T2, actually, despite the fact that it's thinner images, loses some of the resolution of gray-white junction. You can see much crisper delineation of the external extreme capsule along with the gray-white matter in just even a thicker cut 2D T2 sequence. Why does this matter? Because the 2D then becomes an incredible tool for estimating the location of various critical tracts and especially in the setting of edema. As you can see in the subinsular metastasis on the left side, the edema around the corticospinal tracts or the internal capsule allows one to easily appreciate that this tumor is actually from lateral compressing medial, allowing us to choose, in this case for me, a transsylvian approach for resection of the tumor. In addition, structural imaging, such as in this following case, can also help us delineate even without the use of advanced DTI where the corticospinal tract is. This is a physician who presented with left-sided weakness, found to have an enhancing intraventricular tumor. You can see immediately on a routine standard 2D T2 sequence, the robust flow voids that emerge medially and supply this tumor. And moreover, in the sequence called the white matter null sequence, which is a structural sequence that's commonly used in functional neurosurgery for DBS targeting, you can see the black tracts of the white matter in the corticospinal tract being compressed by the tumor, with obliteration of the thalamus in between because of the size of the tumor. This corresponds perfectly to the corticospinal tracts on DTI, but allows for a very quick estimate of critical tracts. This white matter null sequence is even more useful for tracts that sometimes can be more difficult to estimate and that we might have less familiarity with, such as the fornix. In addition, a sequence like the following can be helpful to distinguish nodular from infiltrative tumor. This is a patient who presented with auditory hallucinations, and on inspection of his MRI, one can appreciate what initially appears to be multifocal tumor in the left posterior sylvian fissure insular area, in the left superior posterior temporal lobe, and in this wedge in between. One can see on another structural sequence called the MP2 Rage Flaws protocol, or even a very fine resolution T1 pre-contrast sequence, that the two of these locations emerge to be dark gray, whilst the third wedge is light gray in between. The difference between nodular tumor, which might be safely resected anywhere in the brain as long as one can approach it, versus infiltrative tumor, which can be admixed with functional tracts and other sort of critical eloquent matter, is that it can be seen here in the functional MRI, where language activation as well as the language tracts cross over this infiltrative area. So these sort of structural images really provide additional tools in our initial inspection without added personnel or added time. The impact of imaging can be further seen in this example. It was a 36-year-old computer programmer who presented with blurry vision, and he was initially sent for a biopsy of a presumed optic pathway glioma. And the reason for that is because you can appreciate this heterogeneous enhancement that extends into his proximal left optic nerve. His optic chiasm, as well as both optic nerves, are very enlarged from this T2 bright signal. However, when one looks at some of these other sequences, you can appreciate the preservation of the optic tracks on these white matter null and other T2 sequences, suggestive that there may actually be a plane despite the appearance of the optic chiasm and the proximal optic nerves. More importantly, the patient's function, which remains overall excellent, dictates that the critical neural structures must be preserved somehow. With that belief in mind and a designing approach to allow for resection of the tumor with preservation of the optic pathways, one can see that this actually turns out to be a papillary craniopharyngioma. An early postoperative scan shows the normalization of the optic chiasm and bilateral optic tracts. Furthermore, in some cases, the T2 estimates the cortical spinal tracts no matter how odd or unexpected those fibers are. In this example of a young woman who presented with right-sided weakness, you can appreciate the splitting of the gray fibers around this round mass. And indeed, when we do more advanced tractography, you can see the fibers of the motor tract, cortical spinal tract, wrap around this as if a baseball mitt around the central ball. Additional tractography shows us that the fibers really wrap around most directions of this tumor except for a small patch posteriorly. That, in essence, eliminates the ability to attack this tumor medially, laterally, anteriorly, and really leaves one or two corridors from the posterior superior or posterior inferior surfaces for resection of this tumor. And so that allows us to design a strategy to safely remove the tumor while preserving the other intimately bound critical fibers. Beyond the imaging, which is the studying the preoperative map of the critical structures that emerge, at the time of surgery, the GPS of that map, I would say, is intraoperative physiology. Physiology has been a critical tool for a long time, but not evenly used across the world. And often I hear colleagues make the comment that the reason why it's difficult to believe in neuromonitoring is because they are in the middle of a tumor and somehow the signals go when they feel everything is safe. It then becomes a great dilemma of whether to continue surgery or to stop. And so intraoperative neuromonitoring falls into two major categories, both of which we've invested considerable interest in developing in recent years. Monitoring is the interrogation of function, whereas mapping is the seeking of that function in advance. And so as we delved into intraoperative neuromonitoring more and more, that we observed the following pattern, which is one amongst a couple of classic patterns that often emerge with brain tumor resection. Here you can see a large tumor, and as resection continues, the monitoring of the somatosensory evoked potentials, or SSEPs, the waveforms start diminishing, followed by the motor signals of the hand or upper extremity, and lastly, some diminishment of the leg or lower extremities. We saw this pattern again and again and realized that this is a reflection of simple mechanics. Because the homunculus of the arm and hand region is lateral on the motor cortex, in removal of a large tumor or when going through the ventricles with loss of cerebral spinal fluid, the brain sags down, allowing for the signals of the hand and the arm to go before the signals of the leg. The SSCP signals are often observed before motor evoked potentials because SSCPs are usually acquired more frequently on a near continuous basis every minute or a few minutes, whereas motor evoked potentials are often acquired every 10, 20, or 30 minutes at the discretion of the monitoring team and the surgeon. And so realizing that this is an artifact of pure mechanics, we then realized we could simply reverse this brain sag by infusing some saline, which is a quick process that takes only a few seconds, and rerun the signals. If the signals reversed in your baseline, we can be confident in pursuing and continuing resection to the intended goal. That, by obligatorily for us, requires high density coverage, as not all muscles are decreased in the similar fashion. So having this high density coverage improves our ability to interpret monitoring changes and also improves our ability for mapping. in the ability to have these artifacts become a well-recognized part of the intraoperative armamentarium really allows us to have confidence in this tool and be able to use it without being crippled or handicapped by the ability of the signals being different than our surgical judgment. In addition, about 20 years ago now, the introduction of cortical-bulbar motor evoked potentials really expanded the ability to better and more sensitively predict the facial function in acoustic neuroma surgery. We appreciated that if this can be applicable to the facial motor function, then it can be applicable to really any motor function of the cranial nerves. And that includes the eye movements, extraocular, third, fourth, sixth, the V3 branch of the trigeminal nerve, the 10th and the 12th, and as well as the 11th nerve. What that means is it unlocks an entire pathway of motor fibers, nuclei, and tracts within the brainstem to allow motor mapping to be performed, as well as motor integrity to be assessed at a very frequent and sensitive pace. And so the combination of both facial or head cranial nerves along with body really unlocks an immense amount of surface area within the brain that can be reliably detected in advance. And so this, when coupled with image guidance, which can come in all sorts of forms and shapes, really allows for steadfastness in approaching any sort of tumor at any stage of training. For me, the most versatile and agile intraoperative guidance tool is that of the intraoperative ultrasound. And the key of the ultrasound, I think, is less in the brand or even the resolution or the probes, but how the ultrasound is used. In most intraoperative ultrasound systems, there is ability to adjust the gain or the intensity of the brightness of the screen. You can see on this that there's 8 toggles, which divides a screen in 8 sections. And so by zooming in to allow the tumor to be as big as possible and making the tumor brighter than the background. Here the tumor is superficial, so you can see that my toggles allow the tumor to be brighter, really allow for optimal visualization of the tumor. In addition, by placing internal fiducials, in this case for me, a simple piece of gel foam, which is brighter than any other blood or tumor that I know of, allows the ability to demarcate the tumor from the very beginning of surgery, as well as track down the operative corridor to the depth of a deep tumor. 2 dots form a line. So placing 2 gel foams or 2 internal fiducials, or as many as one wants, 3, 4, as many as necessary or helpful, really allows for the implantation of versatile and not in the way internal fiducials during tumor resection. You can see that here, a small piece of gel foam is put underneath the capsule of a pontine tumor, and a sweep of the ultrasound in 2 orthogonal directions allow for the creation of a 3D map of where this internal fiducial is. That, if one desires, for those who use neuronavigation, I am a big fan of not having any interruption of flow during tumor resection. And so rather than stopping and using a pointer to see how far resection has happened, by placing a tracker on the instrument, in this case on my bipolar, one can see exactly where my tip goes during resection of this insular tumor. And my partners at the Brigham have also developed additional software that allows for easy visualization of the nibbling away of the breadcrumbs during this method. So why do we need so many tools? I would say that this is analogous to the fact that we had beautiful maps of Boston even 100 years ago. However, that still does not replace the fidelity of having live tracking of Google Maps that carries us step by step in the most efficient manner from any destination to my office door. And so having these tools and giving us the reassurance, I think it amplifies the confidence at any stage of experience and really allows for a democratizing process in terms of the ability to achieve safe and consistent outcomes. To put that into examples, I'll go through a few cases from top to bottom. The first is a 55-year-old woman who presented with left-sided weakness and brain fog. Imaging showed the classic appearance of an expansile, heterogeneously enhancing right insular high-grade glioma. You can see that despite the size and overt appearance of this, on the T2 sequence, there is actually fairly sharp demarcation of the medial boundary of this tumor, allowing for great promise in being able to resect the tumor with excellent delineation of the normal brain from the tumor boundaries. As expected, the cortical spinal tracts are deflected medially to the tumor, as with all insular gliomas. For me, I chose a right pterional transsylvian approach with all of the tools that were just discussed, the analysis of the preoperative imaging, the neurophysiology, intraoperative guidance, as well as the use of intraoperative imaging, including intraoperative MRI in this case. High density coverage for insular tumors for me involves coverage of the face, arm, and leg, because the face is the closest point of motor mapping to the depth of resection in large insular tumors for me. So starting from the approach, here is a typical transsylvian approach in which we follow the MCAs to the depth of the insula in short fashion, and very quickly can then appreciate that the expansile tumor, which emerges to the surface, can be easily exposed right there within the fissure. Opening up the fissure from inside out allows us to then see the entire dome of the tumor very readily, placing two small gel foams, one at the front and one at the back of the tumor, and then doing ultrasound sweeps, which allow us to see the gel foam, this very bright white at the back of the well-demarcated tumor. And then as we sweep forward, the second gel foam at the anterior fissure at the other end of the tumor. This allows us to set internal landmarks, as much as we want, and then proceed with resection. Here, I'm just placing a small cotton ball to hold open the operative corridor, placing in an electrode grid to allow for continuous direct motor evoked potentials during the resection, and then ensuing with the tumor resection. Here you can see the tumor is clearly pink and well demarcated from the surrounding brain, allowing first following the insular tumor for debulking. You can see the middle cerebral arteries skeletonized in the center there, and then following to the orbital frontal region where the tumor can be easily peeled out until we see the landmarks of the putamen emerging. That's the nutmeg gray at the depth of the resection there. At some point when I anatomically feel that I am close to within a centimeter or less of the motor tracts, I switch to a monopolar suction stimulator, which allows for continuous dynamic interrogation of the motor cortical spinal tracts during resection. Here you can see that as soon as I insert the stimulator suction, we get robust left arm motor responses at 6 milliamps of stimulus, which corresponds to 6 millimeters of distance from the cortical spinal tracts. At some point during resection, we also notice the following, which is that our baselines, which are in red and bright blue in terms of the peak, quickly drop despite increasing stimulation intensity. This because I am confident that I have not coagulated, caused ischemic injury, or went beyond the borders of the tumor, then suspecting that this is brain sag from removal of large tumor, we simply infuse some saline and rerun the motors. And you can see that with irrigation, the signals immediately, within seconds, emerge back to baseline. This allows us to have the confidence to continue resection. Here is skeletonization of the lenticular striates, and you can see the nutmeg putamen there surrounding that. And at the end, the key of being able to be much closer than 5 milliamps or 5 millimeters to the cortical spinal tracts is avoiding coagulation, in my experience. And so not coagulating the depth, you can see the nutmeg appearance, the gray with the peppered white on it of the putamen along the entire medial surface of the resection cavity, and allowing hemostasis simply with a little bit of glue rather than any coagulation really minimizes ischemic injury. The intraoperative MRI shows a small hematoma in the temporal resection cavity, which is easily cleanable. And at the end of the surgery, we then have stable motor evoked potentials, allowing us great confidence, no matter how the patient initially wakes up, that they will gain steady recovery. The importance of an aggressive tumor is perhaps less so the gross total resection that is achieved, but rather that the patient, in the case of a glioblastoma, can have improved function, return home, and not have any delays in their initiation of subsequent chemoradiation from surgery. The same concepts apply if we go a little deeper into the brain. In this case, is a 31-year-old man who presented with severe debilitating headaches. Imaging shows a well-demarcated right anterior thalamic tumor. And of note, this tumor extends from the anterior thalamic peduncle lateral to the caudate to go lateral into the frontal subcortical region. Because of that lateral extension, I applied all the tools that were just discussed, including the high density monitoring of face, and in this case, also monitoring the oculomotor nerve and nuclei at cranial nerve 3, which is at the depth of the thalamus as a posterior inferior boundary, applying continuous motor evoked potentials. And here I chose a right superior frontal sulcus approach in order to reach more lateral to the caudate head. Entering the ventricles allows for a gush of CSF egress, and fairly immediately we can appreciate the expansile tumor in the medial thalamus. And that, as resection continues, motor signals along with the loss of CSF causes a drop in signals. And so you can see we infuse some saline and can see the signals emerge back to baseline. That allows me to continue with confidence in resection of the abnormal appearing tumor with preservation of the thalamostriate and other critical deep vessels at the end of this tumor. Once the tumor is rolled out at intermittent, however much I want, I can check the ultrasound to assess the extent of resection. When I think that I'm close to the boundaries, I insert my monopolar stimulating suction, and you can see my movements slow down to allow for interrogation of the motor tracts. A septostomy, in my view, is very helpful for resection of thalamic tumors because of the high confoundance of potential CSF issues following treatment. And so the postoperative MRI, again, ensures gross total resection. And you can see in this midline high-grade glioma, the patient will need subsequent chemoradiation. He is able to return home in excellent function with resolution of headaches and to allow nothing to delay initiation of treatment. The same principles apply as we go further caudal in the axis. This is a 67-year-old man whose living is a truck driver of a large 18-wheel truck up and down the east coast of the United States. He presented with leg cramping. Now, in my view, leg cramping is perhaps not unexpected when one drives a large truck for 18 hours a day. However, that prompted an MRI several years ago. And that MRI showed a T2 bright right anterior pontine mass without any restricted diffusion or hemorrhage. And so it was unclear what this meant, but because he was without any deficit, we decided to observe it. It was stable for the first year and a half of observation, and then with COVID, he was lost to follow-up for a period of time. When he returned 2 years later, this lesion had grown much bigger and unfortunately started having contrast enhancement. A PET scan of his body did not reveal other overt sites of disease or cancer at that point in time, and surgery was planned. Even in the few weeks that it took for him to get scheduled and come to surgery, the tumor continued to grow. And now you can see that in this expansion of the tumor across the midline, his internal capsule or his descending cortical spinal tracts are compressed somewhere within this single millimeter or less of fibers at the ventral portion of the tumor. The cranial nerve 6 and the MLF are probably compressed laterally. Of note, he did not have any double vision before surgery, but did have new and progressive left leg weakness. Given that his living is that of a truck driver and he lives independently without family, it was critical for me to be able to preserve his motor function as well as his extraocular movement so that he had no double vision following surgery. Inspecting the images closely, I felt that the only area where the tumor came to the surface was right at the kind of anterior inferior aspect near the jugular tubercle. That allowed me to design a transmastoid retrosigmoid approach with drilling of the jugular tubercle to allow us to really mobilize the sigmoid sinus and come anterior inferior to this. You can see the placement of the gel foam in this, which allows us to then be able to perform ultrasound sweeps, confirm where the internal fiducial is, and establish a new baseline for the appearance of the tumor. And that then allowing for an inside-out central debulking, followed by a peeling of the tumor, allows us to get to with, here you can see the monopolar stimulating suction in my left hand with the stimulating tip, allows us to really get to the brainstem surface and have very clear control and appreciation of as we approach that extremely compressed descending cortical spinal peduncles. You can see the progression of the motor mapping as we pursue surgery, which goes from 6 to 3 to 1 milliamps of motor mapping to, in this case, the left hand. And as long as there's no ischemia or coagulation with countertraction to the resection, it remains very, very safe. Likewise, you can see the left facial muscles emerge at 2 milliamps or less than 2 millimeters to the facial nuclei in this case, and not shown here, but similar observation was found to the abducens nuclei, the sixth nerve, along the medial aspect of the resection. That really guided for me the extent of resection that was safe without causing any contraction or avulsion of the critical tracts. And most importantly, the fact that this patient was able to drive himself to his own postoperative visit and have preservation of the eye movements as well as his strength really allows for the goal of surgery, especially in malignant tumors, that they're able to immediately proceed then to radiation for what this turned out to be a metastasis. Putting this all together from top to bottom is this case of a 19-year-old boy who initially presented to an outside hospital with a blurry vision and was found to have papilledema from a pineal region mass. He underwent a shunt placement by his local neurosurgeon, and this lesion was observed over the years. 4 years later, there was growth of the tumor, which then exploded in the trajectory of growth over 6 months. He underwent 4 additional surgeries by his local team, including shunt revision, a right transcortical trajectory for thalamic biopsy, as well as the left pterional approach for suprasellar biopsy of this lesion that extends from above the suprasellar area, above the stalk, to extending down all the way to the fourth ventricle. Those left him with significant left-sided weakness, as well as a continuously growing tumor. And by the time that I met him, he was sleeping over 20 hours a day with extreme weakness, especially on the left side with high spasticity and significant gaze palsies in all directions. Close inspection of this tumor shows that that makes sense given the fact that bilateral thalami are extremely compressed, as well as the midbrain that one can barely tell where any of the dorsal midbrain structures are in this solid and mostly solid lesion. You can see the tumor extend all the way down to the level of the pons and also extends to the floor and beyond the floor of the third ventricle. Knowing that this tumor extended below the floor of the third ventricle, given that trajectory of growth from his interval imaging a few months before, as well as all the way down to the mid-fourth ventricle, that to me dictated that a interhemispheric approach to allow for 2 directions from a single corridor, anteriorly and down and posteriorly and down. And so integrating the same tools as we have talked about, applying that allowed for immediate resection of the majority of the tumor. But you can see the initial postoperative MRI, despite the fact that I could see the aqueduct and follow the tumor down, still showed a residual nodule that turned out to be not in the fourth, but a separate nodule that was in the left dorsal midbrain, with a little sliver of gray, suggesting of intact fibers that was medial to this nodule. The importance of this, of course, in that aqueduct area is that the nuclei for the third nerve lives here in the periaqueductal gray region. And so wishing to return him to his maximum function, we then went back in with motor mapping and corticobulbar motor evoked responses of the face, including the third nerve, the sixth nerve, and the seventh nerve. And you can see here that we get robust responses of the third nerve bilaterally at 1 milliamp, corresponding to 1 millimeter or less of distance, and robust responses of the facial at 0.02 or far less than 1 milliamps to the face region. All of that allows us to really resect the tumor safely without touching any of his normal structures, and allows reconstitution of what could not be seen before, which is the bilateral thalamus, the midbrain, including preservation of his oculomotor fibers, the bilateral colliculi, as well as preservation of his fornices, which you can see above the internal cerebral vein. This is critical in a young patient to really allow him to be able to go to college and return to school. You can also see that by removing the tumor, this reconstitutes the cerebrospinal fluid flow, which you can see well on the T2 space sequence, the robust flow void of the jet through the floor of the third ventricle, as well as through the aqueduct. Although I did not remove his previously placed shunt, but I don't think he actually needs a shunt for the remainder of his life. More reassuringly, even within a month after surgery, he was able to improve to be able to walk with assistance. Within 8 months after surgery,
Wait,
he
I
could
don't know
walk
if it's right
independently
there.
without assistive device
left,
and have his normal eye
center,
movements once again,
and down.
such that now he's back to college
to
within less than a year after surgery and doing well. The pathology confirmed a mature teratoma, which is a benign and surgically curable lesion. And most reassuringly, as in all cases of surgery, benign or malignant, that we can really preserve anatomy and restore function with the use of these tools. So with that, I'll end my talk. And thank you for the opportunity.
Thank you very much for a very, very nice presentation and wonderful surgical outcomes. I was very much impressed with the all of your cases, but especially with the last one. Yeah, as being the same surgeon, that's kind of an overwhelming type of tumor, I guess. Is there any questions from the panel or from the audience?
Yeah,
Or
I have some question, Professor. Thanks, Professor Venya. Very nice presentation. I've about 3 questions. One is, what's your opinion regarding a comparison between functional and MRI and awake craniotomy, and what is the role of metabolic scan in oncology cases, especially PET scan? Second question regarding position of patient. Do you think that a non-brain retraction gravity assisted position versus ultrasound friendly position, where you can put fluid, another one you cannot put fluid, which one is your preference? And what's your opinion regarding this T2 signal? T2 signal in glioma, would that T2 signal will assist you in terms of consistency of tumor? What are the CUSA setting? What are the instrument that you need? So on and so forth. Thank you, Professor.
Thank you so much for those very thoughtful questions. I think they strike at the heart of much debate in the field of neurosurgery. With regards to your first question about the role of both standard and advanced imaging, I've learned a lot from Professor Ugoture, who frequently says that he has many tools and he uses them all, but trusts no one. And so I do believe in that I'm privileged to have many tools and use them all judiciously. But ultimately, I feel that as a neurosurgeon, if a bad outcome happens, we cannot blame our technology, and instead has to use our own surgical judgment and our knowledge of anatomy and everything that we have trained on. So with respect to awake mapping versus functional mapping, functional MRI, I do both. For language, language in the neocortical regions, I tend to favor awake because we don't have a great way of monitoring that in the sleep setting. For tumors that are in the insula, I do strongly believe that within the insula proper itself, it is devoid of language function. And it's only when we get to the tracts outside of the insula, especially, whether it's posteriorly or superiorly, that those issues emerge. And so for the insula proper itself, including anterior extension and temporal extension, I typically do those asleep, because for me, the sleep setting is easier to monitor motor, and I can get down to 1 to 2 milliamps very reliably with high with a high recovery in a steady fashion for motor function. So I do get functional MRIs, but ultimately it's the location and anatomy of the lesions and our kind of scientific understanding of the functional tracts. In terms of PET imaging, we also use that, but at the same time, I tend to think very simplistically that to offer surgery for a tumor patient, I have to be able to offer one of two things in general. One is to improve their quality of life. Two is improve their quantity of life. It doesn't have to be both, but hopefully it is at least one of those two. And so the PET image for us has been less used for glioma surgery, perhaps more used for recurrent metastasis. And in this day and age, especially of immunotherapy and the desire to minimize steroids, it becomes less and less relevant to us, the distinction between radiation necrosis or asymptomatic recurrent metastasis, because if there's significant mass effect requiring prolonged steroids, we might offer surgery for that purpose. For your second question, in terms of the role of T2 signals and tumor consistency, I do think that there is a role, but it's probably less in terms of the brightness of tumor, but certainly there have been very bright T2 gliomas that have not been so suckable. I tend to think that adult low-grade gliomas are like mochi. They're soft but not suckable, but pediatric low-grade gliomas are like, tapioca. They're slurpable and a delight to remove. And so the biggest role of, for me, the 50 shades of gray in a T2 sequence matter a lot. Very well demarcated gray suggests nodular tumor, whereas the fluffy infiltrative gray, suggests potential danger in the appropriate settings. And also, one of the helpful things about a T2 sequence is that if I can distinguish the tumor from the surrounding edema or brain on a T2 sequence, on a true T2 sequence, not T2 flare or T2 other, but a true T2 sequence, then I can find a setting on the ultrasound to distinguish the tumor from the surrounding structures. That becomes very important in instances of radiation necrosis or other sort of recurrent settings. For your third question, gosh,
Position.
can you
Position of the patient. Position of the patient.
Yes, I don't use fixed retractors in any surgery, but I also am I'm fond of ease, and so because I don't have much muscles or patience for positioning, so I use the simplest position possible. That is a version of supine. If I can get away with it. So in general, most of my positioning allows for the use of ultrasound. But the importance, I think, of what you said of, brain retraction or avoiding brain retraction, which I'm a big believer in, and the use of ultrasound, the key of having an internal fiducial, because many people will say that ultrasound is difficult in the posterior fossa because the lesions are deep and maybe the ultrasound probe can't touch it. But having an internal fiducial is the moment that I realize being able to see the lesion, the mass, whether it's a cavernoma or a tumor, has nothing to do with touching the ultrasound probe. All I have to do is to see the relative position of the internal fiducial, which is that piece of gel foam, relative to the lesion. And so it can be as deep-seated as possible. You can easily tuck that gel foam underneath a cranial nerve, a coursing vessel, arachnoid, a little sulcal slit. So it can be anywhere. And you only need a momentary ultrasound sweep because you just need to fill up the cavity long enough to see the relative position of that localizer, that internal fiducial relative to the lesion. So positioning becomes about convenience for me.
Yeah, in my practice, I use Surgicel as position. Thank you very much, Professor. Thank you.
All right, thank you very much. That was a great discussion. Ben, you have a question?
Yes, and thank you, Professor Linda, and it's my pleasure to meet you here in ACNS webinar. I'm Ben from Queen Elizabeth Hospital of Hong Kong, and I really congratulate on your results, and it's really impressive to see the patient's outcomes. So I have three technical questions. In your experience, how would you think that with the advance of the endoscope and the exoscope, would that change the practice, that how you choose your surgical approach to this deep-seated lesion? My second question is about, I saw that in your presentation, So I saw that you have tracked bipolar. So I haven't seen this tracked bipolar. Is it tracked with neural navigations? Can you share some information with me if possible? My third question is about your last case about I saw that you put the contour in the cerebral aqueduct. Am I right? And put a is that the aqueductoplasty that you did after the tumor removal in the MRI? Yes, I saw that this. I also I want to ask about your experience in choosing the correct size for this the aquid for the stand for the aqueductoplasty. Because sometimes we've experienced that sometimes if it sometimes the patient have some symptoms related to the tetum or tegmentum, whether it could be related to the size of this contour. So
Sure.
thank you very
Oh, great. Thank you also for three great questions. I'll start with the last one. I did not put any stents into the aqueduct. The T2 space is a sequence of T2 that allows for magnification of flow void. And so this is simply, you can see on the regular T2 on the left that, this is a clear aqueduct. And so this is simply the robust flow void from CSF passing through. So I actually don't have much experience with the use of aqueduct stenting or plasty, but this is just the reconstitution of normal CSF and anatomic pathways just by removal of the tumor. For your second question, which
much.
was the track
The
bipolar. It's a regular bipolar. I very
Okay.
simple tools, and in that particular case, it was just a brain lab tracker, which screwed onto the top of the bipolar. We've experimented a lot of putting it onto suction, the bipolar, the right hand, the left hand, because I'm right-handed and because the bipolar has a little shaft at the top. So after various experimentation, ultimately for me, it's usually easier to screw it to the top of the bipolar as opposed to switching hands, depending on the laterality of the case. So it's a reusable tool that it comes with any standard system. Medtronic and other systems also have it.
I see.
For your first question,
Yes. About the endoscope and the exoscope.
yeah,
In your
thank you.
experience, yeah.
Absolutely. I don't have much experience with the exoscope. I'm very fond of using two hands, and more importantly, I'm even more fond of three-handed and four-handed surgery for two reasons. One is having a third hand of an assistance for me is a simple best way to help train residents and fellows because you have to see your hands move. And so I'm a big believer in the tango under the microscope that, until they can get to high risk surgeries, I do expect for everyone to have an instrument, whether it helps me or hurts me in the field. And so that also does help me ultimately by releasing one of my hands to not hold a suction and to allow for the traction, counter-traction of bimanual jeweler dissection, which I think in some of these deep-seated structures is critical. I use the endoscope frequently in deep-seated lesions, intraventricular or whatnot, because it allows the angle of inspection. And so that, is quite helpful in many circumstances, but I do use the microscope primarily. I don't have much experience with the exoscope, but I think that anything that allows for bimanual dexterity in the user's hands is probably the best strategy.
Thank you so much.
Thank you.
All right, thank you. Do we still have some time, or are we waiting for the second speaker? If so, I can ask several more additional
I think we
questions.
can ask because our second speaker not here yet. Yeah, may carry
Oh,
on.
okay. So from me, I have several questions. One is about the last question actually. So navigationizing the instruments using brain labs and that kind of thing. I have done that too, but for me, sometimes those the reflector balls get into your way under your microscope. Don't you have those kind of problems with the shaft?
I don't. And
Oh, really?
probably for a couple reasons. The bipolar that I use has this little black part at the top. And so we just turn it so that it never hits my hand. We experimented with it, in various ways in the beginning to ensure that this is actually drawing is probably slightly inaccurate. In real life, the balls are probably turned this way so that the axis of it never hits my hand, including the thumb. Secondly, the way that my ergonomics is set up, in the room. As you might be able to tell, I don't like interruptions in the flow of a tumor resection. And so the ergonomics are always set up such that, if I'm coming from the right side, the nurse is coming from the left side, and my brain lab points to the back of the left side. So the nurse and myself and the microscope never have to move, meaning the eyes, if I'm at 12 o'clock, the eyes are at 1:30 or 10:30. And so that for me allows for my hands not being in the way, the microscope not being in the way, and the circulator and scrub never having to move from their position.
I see. So I think there is some kind of a learning curve for the surgeon and for the team to get that thing done in a very efficient way, I guess, because I wasn't able to reach to that point. So, and I stopped it at some point of doing that.
It's
A
true.
second
I think for all of us, anything that takes more than a minute or two probably goes out of the armamentarium.
Yeah, and another thing is about neuromonitoring, like motor evoked potential. So yes, I agree with you that you can come close to the fibers, but for example, for insular gliomas, it's not only about getting close to the fibers, but actually trying to avoid ischemic events at the depths of the surgical resection, and that's one of the trickiest spots, especially if it's an enhancing tumor. The perforators are sometimes incorporated into the wall of the enhancing lesion. Isn't that correct? So in that case, maybe MVP is not going to help you. It will tell you that maybe you did make ischemia or violated some critical structures. And do you have any nuance of those kind of issues?
Yes, that's a great point. So in terms of infiltrative versus non-infiltrative, I have not found I've not had any ischemic injury, thankfully, to any insular resections, high grade or low grade. And I think the helpfulness of the mapping, which actually, frankly, for an insular tumor, for a standard insular tumor, meaning not the infiltrated types that violates boundaries, doesn't actually get that close. Everyone thinks that it gets close at the posterior end, but the putamen and the, I think, homunculus of the internal capsule still allows for about at least 2 to 3 millimeters of distance at the posterior end of a large insular resection. It's the anterior inferior aspect that gets close to the facial motor fibers. And that's why for me, the face is the most helpful monitoring. I think over time, the wonderful thing about these tools, over time, if I had to operate in a large insular tumor without monitoring and without any of these tools, I probably would have a similar outcome at this point in time. But especially early on, such that experience does not necessarily translate to worse outcomes for patients, that I think these tools are very helpful. In terms of demarcating the landmarks, as you said, ischemic injury, one of the helpful things of motor mapping is that I do not use bipolar coagulation within 5 milliamps of stimulus. And so everything is cold resection. I actually don't use CUSA I think someone asked me in glioma surgery in general. And so because of our techniques of the regulated suction, with a large suction that can be very gentle and go from high force to low force in a split second, it basically allows me to have no heat for the resection. And I think that does help with the medial borders and the perforators. Secondly, the beautiful thing of the perforators is that they are so reliable, I think. the insular veins or the lenticular striate veins emerge before the lenticular striate arteries, and having the little subarachnoid sleeve of fluid around the lenticular striate arteries allows for a steadfast landmark. So once I see the veins, I can know that the arteries are coming up. Secondly, the putamen is also very easy to identify in a large tumor. I think it's actually more difficult in a smaller tumor. But in a large tumor, the medullary veins are always coursing along the surface, anterior to posterior. So once I see thin little vessels coursing from anterior to posterior, I know that I'm one cell layer away from the putamen. And so anatomically, I have a mental, stop.
Mhm. Yeah, I think you made a really nice comment on, especially for intermediate and young surgeons who are going to start doing these insular tumors, that looking for the lenticular straight veins are sometimes much more helpful than trying to find the lenticular straight arteries, right? I guess. Yeah, that indicates that you are getting very close to the lenticular arteries, vascular systems. Because I'm a big fan of insular tumors, what do you think about going transoperculary? Because I once
需要那
used
什么，就是上不了。好的，
transfusion.
好的，好的。
Yeah. So yeah, I used to use transcription approaches, but I had this really bad experience of sucking one MCA branch to my CUSA. Well, fortunately, it didn't become a disaster. I was able to avoid that disaster, but after that, I started changing my approach through a transopercular approach. How do you think about that and compared to the transcription approach?
Yeah, that's a great question. I certainly have much more experience with the Transylvian approach than the transopercular approach. So some of this is limited for me. But I guess, maybe I'll share this. I didn't get to the insular part of the talk because there's just so much fun stuff to think about. But in general, for me, within the insula itself, I do use the Transylvian approach, whether it's right side, left side, high grade or low grade. And to me, to paraphrase, I guess, the words of Ali Krish when he talks about the cavernous sinus, I do feel that the insula itself is both a route and a destination. And so the issue is not the insula in general for me. It's the extension outside of the insula. So those cases in which I've had experience either because the patient has surgery before elsewhere or what, various circumstances or the recurrence dictated it, and we use more of a percular approach. I find it difficult to bend over and bend over the top and bottom to reach the middle of the insula, meaning that the reach can be limited. And at least for me, no matter how careful I am, the pia bleeds more as opposed to the arteries. Splitting of the MCA arteries, it's just so reliable in terms of having goalposts of resection. And so here in this example in the middle, you can see this is a tumor with a subopercular spread. And so all the vessels that were embedded in the middle were quite robust, but being able to go in and having a combination of a subopercular boundary as well as a Transylvian boundary to scoop out the vessels, I thought was the most challenging part of that resection. And so I guess for me, I still enjoy the MCAs. I feel safer with them. Many people come to the Sylvian fissure last. I come to it first because it gives me safety to know, that point where the MCA divides in the middle of the insula is approximately the midpoint from the anterior, from the superior to the inferior. So it gives me a mental map of how far I need to reach up and how far I need to reach down. Also, it's about the 1/3 mark from anterior to posterior. So also it gives me an internal fiducial of how long I need to reach to get to the posterior tail. So I am a big fan of the Transylvian approach because that's what I learned from my mentors and my teachers. But I think it's whatever is safest, in your hands, in anyone's hands.
Yeah, I totally agree with you. So I think the important thing is to be not dogmatic, I guess, to have as many options as possible so that you can provide the safest route for any kind of a tumor. I think even if the tumor is in the insula, the situation might be different between each cases, like you said, how the vasculature is incorporated or how much upwards or downwards the tumor is extending, and that kind of a thing will affect the surgical approaches most appropriate for each patient. For you're and about the intraoperative imaging, I I assume that your institution has an intraoperative MRI, don't you? Like the Amigo system, right?
We do. We do. I only use it about once a week, just for time and space and so on. And so in the beginning, once or twice a week, I should say. In the beginning, I used it for low-grade gliomas, but over time, I actually am more and more fond of intraoperative MRI for recurrent high-grade gliomas because there the margin of safety is so narrow. The patient has to be, they're already in an aggressive disease on recurrence. They have to be perfect. So I have very rarely do I question if will my patient recover after surgery, thankfully. But the question of where I define success is the pace of recovery. If they can't be back to their baseline or better by the time I take their stitches out, then I have not succeeded. So, especially in a malignant case, I think that's critical. In a skull-based case, we have a little bit more margin. We can give them weeks, or even months sometimes to recover a cranial nerve. But in intraaxial tumors, that margin is much narrower.
I see. I asked this question because you didn't have any comments or discussion within your presentation today. What your thought are about intraoperative MRI compared to, for example, intraoperative ultrasound or other guidances like intraoperative fluorescence, for example.
For me, the ultrasound is my single most important tool next to the suction regulator and the bipolar. And so I really find it so versatile. It's inexpensive, it's fast, it's real time. So we have the privilege of having an intraoperative MRI, and certainly, I will chase the last cell to the 10th hour if necessary. But I think the ultrasound in general is a much more versatile tool.
I see. What do you think about how far you're going to go into the T2 flare resection, for example, for GBMs or higher grade gliomas?
Yeah, that's a great question too. It depends on so I'm less fond of flare, even though that is the basis of treatment for radiation. On the true T2, I look at the shades of gray. If I think there is nodular tumor, I sometimes am perplexed by the discussions of supratotal resection or IDH wild type versus IDH mutant extent of resection, because I think there can be heterogeneous enhancement within a much larger, well-demarcated T2 area of tumor. And so as long as it's well demarcated and I can see the tumor microscopically or in a safe region, I'll go to whatever the boundaries of safety is, I guess. If it becomes truly looks like brain under the microscope and it becomes that fluffy, less, more closer to white matter T2, I at least yet don't do a huge boundary because I do think that even the cognitive changes that can sometimes come from, significant frontal lobe removal makes a difference in some patients' lives.
I see. Well, actually, currently in Japan, we are doing a prospective randomized phase 3 study for flarectomy versus a conventional gross total resection for GBMs right now. Hopefully, we can show our results in about 6 years or so. So
I look forward to looking from
yeah,
that.
we look forward to it. Okay. Ben, you have a question or a comment?
Yes, just want to further discuss about the phlebotomy, because I also encountered these situation clinically, and even though it has common cases, and we keep discussing this in our preoperative meeting. I would like to ask for this because sometimes it's for recurrent cases. The flare signal, you don't know whether it's related to the radiation or the recurrent itself. So sometimes they're located in the eloquent area. So I would try to use those sodium fluorescein in surgery to help to delineate. So in your opinion, what do you think about the use of the sodium fluorescein versus the Gowland. What do you think?
I don't have experience with the sodium fluorescein. We have used 5-ALA. For me, the 5-ALA does not necessarily change my surgical decision making more than all of the other tools, that we use routinely. I guess I tend to be afraid of hurting the patient in any way. So if my internal sensors start worrying that the patient won't be perfect in a short period of time, I get worried if my common sense is discrepant from the data that's seen. My nurses, I do believe that for most tumors, about 80% of the tumor comes out in 20% of the time, and 20% of the tumor takes up 80% of the time. And so it's where to draw the line of the cell chasing, that between when we are confident of having provided, an excellent surgery, but also that we are not responsible for any further decline or deficits. So I morally struggle with the boundaries in every case.
Yes, it's really a mystery for a really mysterious question for me. Sometimes with the ultrasound and all these gadgets, I cannot know the exact amount that I should reset. And I can see that in your dissection. Because sometimes I see in your cases your patient recover so well. I wonder because sometimes after the surgery, those edema or small perforated injury might set in, causing a transient deficit. What is your tips to avoid those scenarios?
Yeah, I don't know if it's because I'm so paranoid about heat. So I really try, if I'm on very eloquent areas, to not coagulate. And so I don't bipolar within 5 milliamps or 5 millimeters of any eloquent tract, as I mentioned. And so that requires for me, and I also don't use the CUSA in glioma surgeries in general, which at least the main reason for that, clearly many far more experienced surgeons like Professor Ture and others use the CUSA or the ultrasonic aspirator avidly, but for me, it generates a lot of heat, at least in our shop. So no matter how much we irrigate, I'm worried about the heat. And I have an easier time dissecting with just jewelers and fine-tipped instruments, the boundaries of vessels, even perforator vessels. So using a large suction, the largest that I have access to with a Cerullo regulator, and being able to stop, at a micron level of perforator vessels, has been reasonably successful in terms of avoiding ischemia.
Yeah, I think that is another very important point, because when I work with my junior colleagues, they tend to use a much thinner, smaller suctions when they get close to some critical structures. But in some cases, of course, not all cases, but in some cases, it might be a better idea to use a larger suction to do a more gentle maneuver. That's your intention, right?
That's exactly right. A large surface area at a low suction, meaning the
With a low
power
suction.
of the surface area is large, so it allows for a gentle peeling.
Yeah, so small suctions will sometimes become something like a needle, and that might hurt the tissues much more dramatically than using a larger suction. It's a little bit counterintuitive, but that's the way that it works in some cases, I guess.
That's true.
So yeah.
Sometimes I think for those malignant cases like the GBM, so they really bleed heavily. So sometimes when you control the bleeding with the bipolar, so will cause some transient deficits, especially for those large DBM and very vascular. So when you control the bleeding, so we are just by partial debulking, they're prone to bleedings. So that's the point.
I have learned from many people, including Professor Shubing, who emphasizes efficiency above many other traits. And so I feel like if I can get through the tumor very, very quickly, even if it's bleeding, but if it's only for 10 plus minutes at a very, 12 suction or larger, then as soon as the tumor is out, the bleeding will stop or slow down significantly. And so devascularization in cases that we can, even GBMs sometimes have a few robust bleeders that you can devascularize first. Of course, for meningiomas, we devascularize first to minimize bleeding before the debulking. But I think the efficiency of tumor removal, weighed against the anesthesia ability to make sure that there can be transfusions if I get to that stage, allows us to get past fairly efficiently.
So have from Professor Shibin, like the GBM is like a concept of AVM. So so is the devascularization that you mentioned is also important. Yeah.
Do you have any comments for, especially for young surgeons, your techniques for hemostasis? I think I got your message that you don't bipopulate anything at the depth of the tumor, and I think that is a very important technique that every glioma surgeon has to master. Do you have any comments on that?
Yes, and so I do use this Tisseal glue. I have no stocks and no financial interest in it, but I do use this Tisseal glue. I mean, it will not start arterial bleeding, but it is very, very effective on venous bleeding. And so aside from removal of the tumor, which I think is the first and most prominent resource for a cause for bleeding, then it's just a wet gel foam. When it's super saturated, then with a wet gel foam, dab it slightly dry, soak it with this Tisseal glue, and then just place it under an even pressure against any sort of surface area. That's my primary, that plus just removing the tumor are my primary forms of hemostasis. I don't use Surgicel or Surgiflow intracranially very much because I do like the sharp cut boundaries of the postoperative scan to track over time. And so I find that some of those other products leave enhancement that can be difficult to follow. And also because I don't like introducing mass effect back. So even the fluid that I irrigate in, I aspirate out to allow the cavities to collapse so that there is no, that's what allows my cavities to collapse in the majority of the circumstances. So that if I'm done with the surgery, their mass effect should be gone.
Okay. Sometimes you apply pressure for quite a long time at the same location so that you can complete the hemostasis. Those maneuvers, do you do that or you don't?
The beautiful thing about this gel foam glue is that it only applies, it solidifies within 2 seconds. So it doesn't allow me more than 2 seconds of pressure. So it will stop even superior sagittal sinus or transverse sinus bleeding within 2 seconds. It
Oh,
doesn't
I've never used that.
that much.
Okay,
Oh,
that's good. No.
that's impressive. Oh. Because I don't know about the use of the gel foam glue before. So like you mentioned about you can stop the sinus the bleeding. So because sometimes when I do the scalp base and we drill the muscle, sometimes we encounter bleeding from sigmoid sinus. So yeah, it's interesting information that I know that we could use
I
those
learned
gel
that from
foam.
Dr. Al-Mefdi. He's a big fan of gel foam glue. If using it on the sinuses, I would say just one thing. For example, in parasagittal meningiomas, we often have to reconstruct, a lateral wall or so on. And so the size of the gel foam, if it's too big, there are a few nuances. I'm happy to email you about them. But if it's too big, it's too floppy of a conduit. If it's too small, you'll plug up the hole and cause occlusion secondarily. So it has to be just the right size, to just be greater than the surface area of the sinus hole so that it just resurfaces instantaneously without causing occlusion or falling in and secondarily, but not so big that it becomes floppy and then can't hold the glue.
Yeah, interesting.
Okay, so since we are still having time, are you still okay? Can you still hold with us, Dr. Bai? Or
Of course.
okay, yeah, for the final case, specifically, I wasn't able to get which approach you were using. I assume that you had a lot of trouble because there were like 4 or 5 prior surgery done for this patient. So maybe you were restricted from those circumstances. Can you give me some more details about it?
Sure. You can see, maybe I'll show you the post-operative scan. So you're right, the patient had a few incisions that I needed to deal with. And you can see from the post-operative scan, one of those trajectories was that the prior surgery took was along a right frontal premotor trajectory. I'm not a big fan of the transcortical trajectory to midline lesion because, first of all, this tumor, the origin of the tumor dictates the pathway of flow for the tumor. And the origin of the tumor was in the pineal region. So it emerged outside of the brain. And so no matter how big and how ugly it grows, it's outside the brain, or I mean, it invaginates in, but I had to have belief that the brain could be preserved somehow despite his existing function. And so just like choosing the Transylvian approach for the insular tumor, I chose the easiest approach that would allow maximum light. And so in this case, it was simply a interhemispheric approach. For me, the anterior interhemispheric approach is defined by locations starting at and anterior to the primary sensory cortex, and the posterior is often from precuneus down to the occipital lobe. The difference of that is that for anterior approaches, I usually do midline, supine, back up, just nice and simple. Posterior approaches, I often will put, one side down. But here, I really thought that a precuneus approach right here, coming behind the sensory and motor regions, allowed me the best trajectory to be able to see directly down to below the floor of the third. Because I knew from this the tumor's prior growth pattern on a year before I met him, that he had 2 separate nodules that met together in the middle of the third ventricle. So he had this nodule right here that was below the floor of the third ventricle, as well as the original tumor in the pineal region going down the fourth ventricle. And so I thought that the most economic way of getting to all areas, because I asked for various opinions, and this patient saw, 5 or 6 neurosurgeons around the country, and everyone has different preferences. But I thought that a suprasellar approach would make it very difficult to bend down and see the middle of the fourth ventricle. A more anterior approach would make it a slightly more a blind angle. For me, a typical corpus callosotomy for a routine lesion is about 1 centimeter. In this case, I pre-calculated that if I coming from the surface of the brain, meaning coming from here, and to be able to get to here, as well as to be able to get to here, I pre-calculated that to me, it wasn't actually this corridor, sorry, I should say it's from here to about here. So this, when I measured it out, is about 1.5 centimeters. So I did make a larger corpus callosotomy than I usually do for these sort of lesions, but that was the only modification from this interhemispheric approach. And then everything else, the brain just falls apart once the hemisphere is split, and making it very, very easy to then just following the corridor down, and you can see at the end of surgery, brain just goes back up, very easy. Though because the tumor is large, that makes it easy. So this is 1.5 centimeters. So you can see the corridor allowing me to create the third ventriculostomy and allowing me to get to the bottom of the fourth. I hope that clarifies it a little bit.
Yeah, it really does. What was the consistency of the tumor? Was it hard, soft, or it was calcified at some point?
So this is a teratoma. So it had very firm, kind of like dried earwax or dried bee wax was really the consistency of this tumor. And in some areas, the nodule that was below the floor of the third, you could see hair and calcifications.
So it wasn't that, well, of course, it's a difficult case, but you didn't have much trouble of trying to break down the tumor at the depths of the surgical field.
So I followed, as in any eloquent location, I did central debulking first, using things like even the transphenoidal pituitary ring curettes, an angled bayoneted sort of instrument, as well as cartouche dissectors for the angled dissectors. And then here, I was very fortunate to have an assistant who could contribute the third hand. So I could really use bimanual dissection to peel the tumor capsule from the internal cerebrals, the fornix, and the thalamus, for example.
At that depth. Wow.
Yes.
Oh, great. Okay. The internal cerebral veins might have been an issue, but because you're coming above, so that the ICVs will be in your way if it's oriented in an awkward way, I guess. If you can grab the middle, maybe that wouldn't be an issue, but those kind of a discussion was maybe done before surgery.
Yeah, so I didn't show it, but in my mind, I am not a fan of surprises unless it's on my birthday. And so in my mind, as I visualized this young boy who's been through so much, I really thought we just had one chance for success, because he was, near death. And as I walk through the tumor visually, well before the surgery, I thought there were 6 challenges that I had to solve to get this. One is the approach, as you mentioned, but how to have the direct visualization below the third and down to the middle of the fourth. The second is dealing with the thalamus. The third is one of them was dealing with the fornix and the internal cerebrals. So it turned out in this case that because of let's see if I wonder if I could show you. I think because of the size of the tumor, the splaying of the third, so the corpus callosum, at least prior to resection, afterwards it actually expanded, but was not very thick. So it's only less than 5 millimeters. And you can also see he had a right-sided shunt. So getting to the shunt catheter allows me to then just follow down, peel the choroidal attachment, the telochoroida of the ipsilateral right-sided internal cerebral vein, because he already had prior right-sided injury. So if anything happened, I wanted to be on the right side. And then that actually was very fortuitous. It did peel well, thankfully, but it actually turned out to protect the fornix, which you can see there. So the internal cerebral vein then turns out to be my shield, that and the shunt catheter of my fornix. And that was really my 6th and greatest consideration, because I wanted him to have preserved memory. Motor and eye movements I can monitor, but memory I cannot monitor. So I have to rely on anatomic integrity for that.
Mm-hmm. If I were in that position, I might have used the occipital transtentorial approach, maybe. I haven't looked into the images, all of the images, so I'm not quite sure, but
No, that's a great point. And the same thought for occipital transtentorial as well as for the suprasellar kind of infratentorial. I worry about the bend down to, I think that is a great access for the majority of this tumor. But the one thing is that there are 2 reasons for that I didn't choose that, is that I wasn't sure I could get all the way down here. And the second thing is, many people, everyone has a different way of choosing their approach to the pineal region. For me, with the belief that learned from Professor Ture, that the colliculi can often be preserved. So the reason that so for me, depending on which direction the colliculus is deflected, I try to choose a corridor to allow preservation of all 4 colliculi. So you can see that despite how things look at the beginning, that really it was only attached to the left superior colliculus a little bit, but the right side could be completely peeled off, and the left inferior colliculus, can be peeled off. So I chose this approach so that I didn't have to cross the clavicular plate.
Mm-hmm. So the fourth nerve is beneath the tumor.
The fourth nerve is it's nowhere in consideration, since I don't come to the tentorial edge. I guess the only area that might come to consideration is at the level of the midbrain, in terms of the nuclei or the other such stuff. But the nerve itself is not visible, because I'm coming from trans corpus callosum, trans third ventricular down to the 4th ventricle.
Yeah, so I mean the fourth nerve was compressed down by the tumor, compressed onto the brainstem. Is that correct? So
Well, I don't really see it coming from the middle. So I don't see the fourth nerve in any way.
yeah, because if you're coming from posteriorly, one of the landmarks will be the fourth nerve, and the colliculus and the fourth nerve. So I wasn't quite sure what kind of a surgical view will be at the end of the depth of the at the end of the surgical stage. So I made that comment. Okay, so I think we have done plenty of discussions.
Congratulations for your very successful presentation. And today we have around 600 audience in the WeChat channel. They learned from you. Thank you.
Thank you very much. It was a pleasure. And thank you for the very lively discussion. Truly a pleasure.
Yeah.
Thank you very much. And I think we just spent one amazing presentation and a great discussion. So on behalf of the Education Committee of the ACNS and the President, Professor Mukato, I would like to thank for today's speaker, Professor Venya Linda, and also the chairs, Professor Manuba Kinoshita and also Professor Swin for their time and support for the ACNS webinar. And again, as Prof. Zubin had mentioned, we got a great number of audience from WeChat channels. And also special thanks to the band for joining us today. So until we meet tomorrow, it's bye-bye from all of us. Thank you, Professor. Good night.